This hearing of the Oversight and Accountability Committee will come to order. I want to welcome everyone here today. Without objection, the chair may declare a recess at any time, and I want to add that we will be recessing. We hope to get all the opening statements in. The House is unfortunately called votes this morning, supposed to be somewhere around 10:30, but we will attempt to get mine, the ranking member's opening statements in, as well as the opening statements of our witnesses. Then we'll hopefully take the recess, we'll have votes, and then we'll reconvene the hearing and begin with the questions. I now recognize myself for the purpose of making an opening statement, but first, without objection, Representatives Buddy Carter of Georgia, Diana Harshbarger of Tennessee, Celeste Malloy of Utah, Mariannette Miller-Meeks of Iowa, and Jake Auchincloss of Massachusetts are waived on the committee for the purpose of questioning today's witnesses. Without objection, to ordered. I want to welcome everyone to today's hearing on the role of pharmacy benefit managers in pharmaceutical markets. This is the third in a series of hearings discussing pharmacy benefit managers, or PBMs, and their role in the pharmaceutical market. At our first hearing, we heard from practitioners who interact with PBMs daily and a transparent PBM executive. They shared how PBMs affect their ability to help patients and can negatively impact patients' health. Dr. Miriam Atkins, an oncologist in Georgia, discussed how PBMs dictate which drugs a patient can use and require the use of mail-order pharmacies. Kevin Duane, an independent pharmacist in Jacksonville, Florida, explained that he is no longer able to serve TRICARE beneficiaries because Express Scripts forces TRICARE beneficiaries to use specific pharmacies on military bases. As a result, hundreds of thousands of uniformed service members and their families have less access to prescription medications. Greg Baker, the CEO of a transparent PBM, discussed the importance of PBM reform in reducing the cost of prescription drugs. At our second hearing, we heard from several stakeholders, including the National Community Pharmacists Association, the Pharmaceutical Research and Manufacturers of America, the Association for Accessible Medicine, and the Pharmaceutical Care Management Association. These witnesses provided testimony that the largest PBMs use spread pricing and abusive rebating practices, making it more difficult for generics, biosimilars, and other competitors to gain market share. We heard that the largest PBMs under-reimburse competing pharmacies while overcharging payers and pocketing the differences. We learned that the largest PBMs steer patients to the pharmacies they own while often charging payers more and providing less care. Now, this committee has the opportunity today to hear from the CEOs of the three largest PBMs, CVS Caremark, Express Scripts, and Optum Rx. In March of last year, I sent letters to CVS Caremark, Express Scripts, and Optum Rx requesting information about each business. Since then, we've received more than 140,000 pages of documents from the three largest PBMs, including details about their formularies, rebates, pharmacy networks, and contracts. In reviewing these documents, we've learned the three largest PBMs have used their position as middlemen in integration with health insurers, pharmacies, providers, and recently manufacturers to enact anti-competitive policies and protect their bottom line. The largest PBMs share patient information and data across their many integrated companies for the specific anti-competitive purpose of steering patients to PBM-owned pharmacies. These PBMs frequently tout the savings they provide for payers and patients through negotiation, drug utilization programs, and spread pricing, but evidence indicates that these schemes increase costs for patients and payers. The largest PBMs force drug manufacturers to pay rebates in exchange for the manufacturer's drugs to be placed in a favorable tier on a PBM formulary, making it difficult for competing lower-priced prescriptions, often generics or biosimilars, to get on formularies. As many states and the federal government weigh and implement PBM reforms, the three largest PBMs have begun creating foreign corporate entities and moving certain operations abroad to avoid transparency and proposed reforms. The largest PBMs' use of tools such as prior authorizations, fail-first policies, and formulary manipulations hurt patients and result in poorer health outcomes. The anti-competitive policies of the largest PBMs have cost taxpayers and reduced patient choice. Today, the committee is releasing a staff report outlining the results of our investigation into PBM policies. Simply put, the committee's investigation has found that while PBM's position as middleman should have enabled them to reduce the cost of prescription drugs and improve Americans' health outcomes, they have not. Instead, the cost of prescription drugs has gone up every year for 15 years. Instead, patients have less choice and worse health outcomes. I ask unanimous consent to enter the committee staff report titled "The Role of Pharmacy Benefit Managers in Prescription Drug Markets" into the record. Without objection, so ordered, I encourage everyone to read this. I'm hopeful that today's hearing will provide transparency and accountability for how PBMs have impacted the market for prescription drugs. I now recognize the ranking member for his opening statement.
Hey, thank you, Mr. Chairman. Welcome to the witnesses. It's the third committee hearing this Congress on the subject, and we finally have the largest PBMs here at the table. Thank you for joining us. Patients say that some of your practices are making it more difficult and more expensive to access the medication that they need, and so we need to hear from you about what's going on. The three companies represented today account for 80% of the PBM market, which means that the three of you sitting here are responsible for the policies and practices that directly affect the lives and the health and the pocketbooks of 270 million people in America, most of whom are not even aware that your companies exist. People don't choose their PBMs. People do choose a health insurance plan, which in turn has a PBM. Most people are offered a choice between a small number of health insurance plans, and then they wade through somewhat confusing language and murky distinctions to find the one that they think is best suited to the needs of their family. Nobody is thinking about the PBM that accompanies the health plan they use. In fact, most people don't even know that the health plan they're selecting is going to be working with a PBM. No one is considering the health insurance plan that they spend hours trying to select is closely affected not just by not just by the insurance company, but also by another enormous business looking to profit. Although PBMs operate way outside of public consciousness, your companies have immense power over patients. PBMs create the list of medications that determine what will and won't be covered by an insurance plan. They determine how much those medications will cost, and they determine which pharmacies a patient can or cannot use to access the medications. Your three companies are dictating these terms for 4 out of 5 people in our country. And I'm glad you're here with us today to provide serious, robust insight into these decisions. While we don't have a lot of visibility into the inner workings of PBMs, the work this committee's done on PBMs this Congress has provided many examples of how your policies are not necessarily always working for the people that are served. The New York Times recently reported that one of your companies was charging patients on Medicare more than $650 for a medication that would have cost less than $50 at an online pharmacy without any insurance at all. A different patient was reportedly charged $211 by one of your companies for a drug he could have acquired at Costco for $22. That's a 10-to-1 ratio between what people are paying through the PBMs versus what they could get in just an out-of-pocket purchase. Who do these policies benefit? Well, obviously not the patients. It seems they benefit the PBMs, which get reimbursed by the health insurer for that higher price. Even if this system works for some patients, it's clear that many served by your companies are falling through the cracks, whether they experience delays in getting the medicine they need or they're forced to overpay. In a for-profit healthcare system, we know companies are going to seek profits, but it's unacceptable for those profits to come at the expense of patients getting the basic medicine that they need to lead their full and healthy lives. Democrats on the committee have long worked to hold Big Pharma accountable for the ways in which they relentlessly manipulate the price of medications and make them unaffordable for tens of millions of Americans. Our 3-year investigation revealed that pharmaceuticals use anti-competitive tactics to stop generics from entering the market and to target the U.S. for high prices because our government simply did not have the power to directly negotiate with them the way that our peer countries do. But last Congress, Democrats passed the Inflation Reduction Act, and the wins from that landmark legislation are already being felt. Beginning next year, Medicare will negotiate drug pricing directly with the pharmaceuticals, and drug companies will now have to reimburse the government when they raise prices beyond the rate of inflation. But we have a long way to go to place people over profits, to put healthcare first. I hope that today's hearing can shed light on the way that PBMs are taking a page from Big Pharma's practices and exacerbating the drug affordability crisis. We need a healthcare system that is going to work for the people. Thank you, Mr. Chairman, and I yield back.
Gentleman yields back. Today we are joined by David Joyner. He's the president of CVS Caremark and executive vice president of CVS Health. He has worked for more than 27 years in the healthcare and PBM industry. Dr. Adam Kotzner, did I pronounce that right? I usually don't. I apologize. Is the president of Express Scripts and Evernorth Care Management. He earned his Pharma D from the St. Louis College of Pharmacy and is a nuclear pharmacist. Dr. Patrick Conway is the CEO of OptumRx. He is a practicing pediatric hospitalist who earned his medical degree from Baylor College of Medicine, a Master of Science in Clinical Epidemiology from the University of Pennsylvania. Thank you all for appearing here today. I'm looking very forward to your testimony and questions. Pursuant to Committee Rule 9G, the witnesses will please stand and raise their right hand. Do you solemnly swear or affirm that the testimony you are about to give is the truth, the whole truth, and nothing but the truth, so help you God? Let the record show that the witness is answered in the affirmative. Thank you all. You may take a seat. We appreciate you all being here today and look forward to your testimony. Let me remind the witnesses that we have read your written statements and they will appear in full in the hearing. Please limit your oral statements to 5 minutes. As a reminder, please press the button on the microphone in front of you so that it is on and the members can hear you. When you begin to speak, the light in front of you will turn green. After 4 minutes, it will turn yellow. When the red light comes on, your 5 minutes have expired, and we would ask that you please wrap up. I now recognize Mr. Joyner for his opening statement.
Thank you, Chairman Comer, Ranking Member Raskin, and members of the committee. I'm David Joyner, President of CVS Caremark. I'm here to provide you with the facts about what we do at Caremark to bring down the cost of prescription drugs for millions of Americans. We've successfully converted 90% of their prescriptions to generics, driving costs to historic lows. That means our patients only pay $8 out of pocket on average. We did the same for brand name drugs. From 2017 to 2022, our proven tools and strategies drove down the net cost of brand name drugs by 15%. Despite these successes, brand products with little to no competition remain the chief source of rising drug costs, spurred by their high list prices. Last year, a new-to-market drug carried a median annual price of $300,000, and Humira, Ozempic, and Stelara alone cost more than every generic drug combined. Humira perfectly illustrates the challenge. Thanks to a strategy of patent manipulation, AbbVie blocked any competition, and it became the single most expensive drug for our customers and their members. The good news is that we were uniquely positioned to promote the adoption of biosimilars, to deliver lowest cost at the pharmacy counter, and to get these drugs to the people who need them. So in April, we dropped Humira from our major formularies, covering only the biosimilars. Today, members are paying lower cost, in most cases $0 out of pocket. And employers, unions, and health plans have realized over $500 million of savings. That's the impact we're having with just one drug. Now, across more than 70,000 drugs we cover, we are leading the industry and our clients by prioritizing products with low list prices while maximizing savings for our employers. And let me be clear, we do not contribute to the rising list prices, a fact confirmed by multiple quantitative independent studies. Hampering our ability to negotiate lower drug costs only benefits the pharmaceutical manufacturers. These drug manufacturers who testified on Capitol Hill said they would not lower the list prices if rebates were eliminated. It would only remove an essential tool in our ability to deliver lower costs for medications. But there's always room for improvement, and I returned to CVS Caremark last year to evolve our PBM by increasing transparency and accountability. We've made major changes that benefit employers, labor unions, public health plans, Medicaid and Medicare, and the pharmacies that we work with. The way drugs are priced and reimbursed today is not transparent enough for patients, pharmacies, or our plans. That's why we've built True Cost, a transparent cost-plus model for every drug that we cover. We show our clients how much we pay and reimburse for every single drug for every pharmacy in our network. For the more than 27,000 independent pharmacies in our network, they will be reimbursed in line with the price they pay to acquire each drug and to provide additional dispensing and administrative fees to cover the services for their patients. Independent pharmacies representing 40% of our network are vital to our work. We reimburse them at a higher rate than we do CVS-owned pharmacies and as much as 25% higher for generics. We also have a network of 700 rural pharmacies with even higher reimbursements, 90 of which were added in last year alone. Despite our work, danger lies ahead for the American healthcare system: the price of GLP-1 drugs. Between skyrocketing demand and price hikes, the costs are simply overwhelming. Ozempic, Mounjaro, and Wegovy drove more than 2/3 of the increased costs for our CVS Caremark customers in 2023. If every adult with obesity received a GLP-1 prescription, costs would surpass 1.2 trillion drugs. We will continue to do what's best, use the power of competition to make these medications available at lower costs to the people who need them. It is our job to provide affordable access to important life-saving medications that improve the quality of life for millions of Americans. We enable employers, unions, and state health plans to take care of their people. And when drug manufacturers want to charge them too much, we are there to rein them in. Thank you.
Thank you. I now recognize Dr. Costner for his opening statement.
Chairman Comer, Ranking Member Raskin, and members of the committee, thank you for inviting me to testify today. My name is Adam Kotzner. I grew up in rural Missouri and began my career as a pharmacist for a regional hospital before joining Express Scripts more than 15 years ago. For decades, our mission has remained the same: helping employers, labor unions, government agencies, and health plans provide more affordable, higher quality prescription benefits to their members. These sophisticated purchasers demand value and drive innovation from Express Scripts every single day. That mission is also very personal to me. In my early 30s, I was diagnosed with stage 3 melanoma, which then progressed to stage 4. I'm here today because of pharmaceutical innovation, and it's why I work so hard to lower costs for more people to access the drugs they need. In 2023, we helped keep average patient costs for a 30-day prescription to $15 for those with employer-sponsored plans. Alongside our clients, we shield patients from approximately 90% of drug costs in the healthcare system. In fact, patients spent less out of pocket in 2023 than in 2022, despite rising list prices set by manufacturers because of our work to negotiate discounts across the supply chain. Our deep clinical expertise helps patients navigate complex care journeys, improve medication adherence, and prevent disease progression and comorbidities. From developing formularies that help guide patients to clinically sound medications to performing safety and quality checks on millions of prescriptions each day, we are the connective fiber fighting to ensure access to safe, effective, and affordable medications. Many members of this committee have expressed concerns regarding the viability of pharmacy access in rural and underserved America. As a pharmacist and someone who grew up in rural America myself, I understand this challenge and agree it must be addressed. Over the past year, we have worked to enhance reimbursement to pharmacies serving these areas, created new pharmacy revenue streams through clinical services, and we've regularly convened an advisory committee of independent pharmacists led by a former independent pharmacist. Over the past 5 years, the number of independent pharmacies in our network has increased by 20%. I know there are questions regarding the transparency of pharmacy benefit services. Transparency is built into all of our pricing models, including our principal revenue sources, arrangements with manufacturers, and pharmacy claims data. Personalized information about the cost of prescription drugs is provided to millions of patients in real time to help them make more informed decisions with their doctors. I also know significant challenges remain. The median cost of a new medication in 2023 was $300,000, up from $180,000 in just 2 years. As newer and more sophisticated therapies continue to come to market with increasingly unsustainable prices, we need solutions to ensure people who need them can benefit from these innovations affordably. Challenging our efforts to lower prescription drug costs are brand drug makers who exploit the patent system to maintain high prices for years beyond the date generics and biosimilars should become available to patients. For example, the primary patent for Humira, the best-selling drug in the world, expired in 2016, but biosimilar competition couldn't launch until 2023 because of the patent thicket constructed by the manufacturer. We applaud recent efforts to drive more competition and address patent abuses intended to maintain high drug prices. These efforts will lower prices for American patients and save billions for American businesses and taxpayers. In closing, our mission and our business model: 1, provide innovative solutions that enable access to medications at affordable costs and improved health outcomes. 2, ensure clients have choices that enable them to deliver accessible, affordable pharmacy benefits. And 3, share additional levels of transparency about the value we create. I appreciate this opportunity to answer your questions about our role and how the value we create reaches patients. Thank you.
Thank you. Dr. Conway.
Thank you, Chairman Comer, Ranking Member Raskin, and members of the committee. I'm Dr. Patrick Conway, CEO of OptumRx, a part of United Health Group. OptumRx is a pharmacy services company that works to make healthcare more affordable and accessible and to improve health outcomes for our customers and patients. I'm also a pediatrician, seeing patients on weekends at a Boston hospital, and I'd like to share one experience from my earliest days as a physician that I will never forget and shapes my mission for patient care. I sent a child home from the hospital with a prescription for a common antibiotic to treat a mild infection. In less than 24 hours, the child was back, readmitted, because when the mother took the prescription to the pharmacy, it cost $200 that she didn't have. A scared kid and a terrified parent spent 7 days in a Boston hospital because they couldn't afford an antibiotic. This was a costly outcome for the system, and most importantly, an example of how we must do better for patients and families. Experiences like that one, the realities that people face when it comes to paying for medicine and accessing care, drive our work at OptumRx. They're what we have in mind when we deploy innovations like our critical drug affordability program that offers low or $0 cost sharing on more than 290 brand and generic medicines, including common antibiotics. OptumRx exists to ensure patients have access to the safe and effective prescription drugs they need while managing their cost. My testimony focuses on how we do just that. I'd like to start with our critical role in prescription drug affordability and access. The high price of new drugs are challenging the healthcare system. In 2023, the median annual list price for a new medicine was $300,000, a 40% increase from 2021. The 5,000 plus customers who hired us, including employers, unions, health plans, and governments, rely on OptumRx to be the counterweight to drug manufacturers' high and increasing list prices. Our negotiated discounts and clinical tools deliver more than $2,000 per person in average annual drug savings. And a recent analysis found that PBMs save the broader healthcare system approximately $145 billion annually. Today, we compete with more than 70 companies that offer a full range of pharmacy benefit services. We compete on the strength of our clinical capabilities, patient support programs, drug trend analytics, and our ability to lower drug costs for our customers. Everything we do is rooted in a clinical foundation, starting with our independent Pharmacy and Therapeutics Committee, which through clinical rigor provides unbiased, evidence-based review of new and existing drugs and their place in therapy. We offer clinical programs and affordability tools to support each stage of a patient's healthcare journey. We also offer our customers a wide range of formularies and pricing solutions to meet their affordability, predictability, and accessibility expectations. We negotiate with drug manufacturers to secure the lowest possible net cost for our customers. More than 90% of prescriptions are for low-cost generics, often without rebates, so negotiated discounts on the remaining 10% of expensive branded drugs are the only check on manufacturers' pricing power. OptumRx passes through 98% of those discounts to our customers. Our customers recognize the value of our work. In a recent survey, 97% of employers said they were satisfied with their PBM, and 93% said that it's essential to have the flexibility and how they offer prescription benefits to their employees. Our customers have diverse priorities, and preserving the options available to them is critically important. OptumRx is committed to providing its customers with actionable transparency that helps them understand their options and how their pharmacy dollars are being spent. We are also committed to supporting our pharmacy partners by, for example, promoting their value as care providers in rural and underserved areas. We support legislation that will preserve and grow options for plan sponsors and how they offer coverage. Congress should also take steps to rein in drug manufacturer patent abuses that have delayed generic and biosimilar launches, inhibiting the true market competition that leads to lower prices. We believe this holistic approach helps promote affordable and accessible prescription drugs. Several legislative proposals currently under consideration would work at cross purposes with these goals. We believe these proposals would not lower manufacturer list prices, but will result in increased drug cost for employers, unions, health plans, and governments. We look forward to continuing our shared work addressing affordability and access to prescription medicines. Thank you for your time today, and we welcome your questions.
Well, thank you all very much for your testimony. We will begin with questions. The House has called votes, but we've agreed I'm going to get my questions in, and Mr. Raskin will get his in, and then we'll take a recess until 10 minutes after the final vote. So I recognize myself for 5 minutes. Mr. Joyner, are you familiar with CVS Caremark's lawsuit with New York Cancer and Blood Specialists regarding DIR fees?
I am.
Last week, the Southern District of New York ruled in favor of the practice and ordered CVS Caremark to pay over $20 million in back DIR fees, interest, and attorney's fees. I ask unanimous consent to enter that ruling into the record without objection to ordered. I understand that other oncology practices are in arbitration with CVS Caremark over the same issue, and you are attempting to prevent those from becoming public. Given the federal court findings, do you intend to pay all practices back for a clear miscalculation of DIR fees, or do you intend to fight them all like you did the New York practice?
Thank you, Mr. Chairman. In specific response to these cases, we do actually comply with all Medicare Part D rules. And in fact, part of this is actually creating network adequacy and also making sure we're managing the network according to the terms and conditions. So in this case, our goal is to apply these consistently across all 65,000 pharmacies, and most importantly, making sure we get the right drug to the right patient at the right cost.
So are you going to fight the other rulings, or are you just going to pay, or just out of curiosity, have you decided yet? The other lawsuit?
Yeah, consistent with what I had mentioned earlier, we do comply with the Medicare Part D rules, and we'll make sure that we're
All
consistent.
right. This next question is to all the witnesses. During the committee's investigation, we found evidence that each of your companies steer patients with long-term maintenance and other high-cost medications to the mail-order pharmacies you own, even though it often results in more difficulty for a patient to get their medication. Will you commit today, yes or no, to steering patients to the pharmacies will you commit to stop steering patients to the pharmacies you own and instead let them choose the pharmacy that is best for them and pay the same price for the same prescription, regardless of where they pick up the prescription? Dr. Conway?
We do provide patient options, including home delivery, and we'll continue to provide those options to patients.
Dr. Costner?
Thank you for the question, Chairman. We focus on our clients, employers, labor unions, government entities, to make those decisions on their plan benefit designs, and so they make the decision on what types of
Are you
pharmacies they
denying
want to provide.
that the PBMs steer patients from the independent pharmacies to your own mail-order pharmacies? Is that?
So we carry out the benefit designs that our clients choose, and that's how we provide our services. For home delivery pharmacies today, the safety and efficacy for those patients.
Mr. Joyner, will you commit to?
Yeah, Mr. Chairman, we will continue to offer home delivery at the request of our customers.
So I'm going to take that as an answer. You're going to continue to steer patients away from independent pharmacies to your own mail-order pharmacy. That's how I interpret those answers. Next, during the committee's investigation, we found 300 examples of PBMs placing higher-cost medications in more preferred positions on formularies. A report that just came out found that not only are you prioritizing higher-cost medications, you're setting dramatically different prices for some medications across the country. The report found that Suboxone, a critical treatment for opioid abuse, is being charged at 600 unique prices by just one of your companies, and another is charging 448 unique prices. Out of the top 5 PBMs, the lowest number of price points was over 200. Your companies have constantly claimed that drug companies set market prices. But if that's the case, why are your companies charging different prices across the country? Mr. Joyner.
So specifically as it relates to creating competition with the manufacturers, we've done a remarkable job of lowering the cost of brand pharmaceuticals. In fact, if you look over the time period of 2017 to 2022, brand name drugs have decreased by 15%. So in keeping with our goal and our focus as a pharmacy benefit manager, it is to create the competition and lower the cost of pharmaceuticals for the customers which we serve.
Dr. Costner.
Last year alone, we saved our clients $64 billion, and we kept patient out-of-pocket costs on a per-prescription basis at just $15, despite brand manufacturers raising drug prices on 60% of those products. It's hard work to keep those costs down for patients and clients.
As you said, manufacturers set the high list prices, but we are committed to providing the lowest net cost options to our clients, so the drugs are more affordable to the people they serve.
So your testimony today, it's not the PBMs, it's the drug manufacturers. That's the answer, because that's not what our report has concluded. That's not what we hear from doctors all across America. That's not what we hear from pharmacists all across America. We hear that you're the problem, and that's why we've had 3 hearings on this. This is why this is a huge issue. This is why just about every state now is taking up PBM reform. There's a credibility issue with the PBMs. There's a transparency issue with the PBMs, and it doesn't appear that the PBMs are being consistent. We believe you have anti-competitive policies. I have more questions, but my time's expired. I'll get some more time in a minute. I yield now to Ranking Member Raskin.
Thank you, Mr. Chairman. I wonder, do any of you guys have high school-age children? You do, Dr. Conway. All right. So don't set this at the elementary school level, because I don't want it to be just you trying to help people, but don't set it at the PhD level, but set it at the high school level. Explain to a high school student what the PBM does and what value you render in America's confusing healthcare system. Could you?
Yes, so the way I would describe it to a high school student is the following. We provide lower cost drugs to the people we serve, employers, unions, state governments, others, and we provide accessible, affordable options to people. It's based on clinical evidence on what medicines are most effective, and then we negotiate for the lowest net cost transparently and provide that information both to the customer and to the patients we serve.
Okay, the graphic behind me shows that when combined, the larger healthcare conglomerates to which your three companies belong control 20% of America's national healthcare expenditures, a figure that has been growing substantially. And the three PBMs represented today, independent of their parent companies, are so big that you would all fall within the top 40 businesses in America by revenue. And this size means that collectively you control nearly 80% of prescription drugs dispensed in the country. The next three largest PBMs account for 5% of the market, and the remaining 60 PBMs account for 6% of prescriptions managed and dispensed, okay? So, Mr. Joyner, let's take you. Excluding the two large companies represented at the table along with you today, of the 60 PBMs that account for just 6% of the market, which does CVS Caremark consider to be, say, its top three competitors?
So there are a variety of competitors, 70 plus PBMs in the marketplace, all competing respectively for customers. This is a highly competitive marketplace, and we basically win and lose based off the value proposition that we present to our customers.
Okay, so who would be the top three outside of the mega corporations represented? Who would be your top three competitors for that 6%?
Yeah, it will depend on the market segment. So there are some Blue Cross Blue Shield solutions that compete effectively within that. So that would obviously be a competitor for that particular segment of the marketplace.
Okay. Would you agree that the PBM should be held accountable to the patients and not just the institutions you represent, or would you disagree with that? Dr. Kautzner, let me ask you.
We're absolutely, Ranking Member Raskin, accountable to our patients. And I think it's important to recognize that.
Can you explain how you're held accountable to
Sure.
the patients?
Every prescription that we process today undergoes 18,000 safety, quality, and benefit checks in less than 1 second. And with that work, we will prevent approximately 100 million potential medication errors this year. So that's how we positively affect patients. We also...
Right, but that's different from the question of accountability. So, I mean, the answer could be no, that's not your function in the marketplace, but is there any accountability mechanism between you and the actual patients, or do you just deal with the institutions, the businesses, the unions, and so on that you represent?
So our contracts are with employers, labor unions, government entities, but we absolutely are committed to patient care and health and care coordination. It's why we employ thousands of nurses and pharmacists within our organizations to provide that high-quality clinical care.
All right, can you explain again and put it in clear terms, because a lot of this stuff is hard for people to understand, okay? Why is it that there are so many cases that the committee has found, the chairman has cited them, where people are ending up being charged 10 times more within one of the plans than they would be if they were just to go and pay out of pocket for a drug? Why does that happen? Can you explain that?
So today, for over 80% of patients in America, they spend less than $250 on all of their prescriptions in a given year. There are 1% of patients where its challenges still exist, where that 1% may spend over $2,000 annually on prescription drugs. That's the group that we are providing patient savings programs for and working hard to provide improved patient benefit designs so that we can keep costs down in that area.
Again, I feel like the more I hear, the less I understand. I mean, I just have one very simple question. If somebody's covered by one of the plans, how is it possible that they've got to pay 10 times more than they would pay if they were just to go and pay out of pocket for the drug? Mr. Jordan, can you explain why that would happen? And I mean, I'm willing to believe, maybe that's not the majority of the cases. I think that's what you're saying, Dr. Gelsner. But why, can someone just tell us why that happens, and it can help us understand the dynamics of this market?
Yeah, as I said earlier, there's a variety of different pricing models in the marketplace today. What you're referring to is what generally is an average pricing that we have contracted with our clients. The good news is, and as I mentioned earlier about coming back into CVS Caremark, is I am trying to change and transform the marketplace, which is in large part why we introduced True Cost, which is a price model that actually allows us to guarantee every drug at every pharmacy across 14,000 different medications. So that would, in effect, get you to the consistency that and actually eliminate many of the headlines that you're referencing.
All right, my time is up, Mr. Chairman. Thank you for your indulgence, and I look forward to questioning by our colleagues, including Representative Auchincloss, who's a real specialist in this, and I hope we'll just get some illumination today about some of these strange things we found. Thank you.
The ranking member yields back. Before we recess, I think an announcement, Director Cheadle just resigned from the Secret Service.
Well done, Mr. Chairman. That was a great hearing.
Maybe you should sign more letters with me. We could get, no telling what we could do.
I mean, bipartisanship might be the wave of the future.
All right. Pursuant to the previous order, the chair declares the committee in recess, subject to the call of the chair. The committee will come back to order. I now recognize the gentleman from Alabama, Mr. Palmer, for 5 minutes.
Thank you, Mr. Chairman. I've got a number of concerns about how PBMs have operated and how it's impacting rural pharmacies. I grew up in rural Northwest Alabama and understand a lot of the pressures that are being placed on independent pharmacies. And I've just got some questions that I'd like to run by you. There's been some significant confusion as to how much of the direct and indirect remuneration fees PBMs retain in the Medicare Part D program. So I'd like to try to clear that up. If you could answer this, what percentage of DIR that your companies receive from competing pharmacies in terms of what percentage are distributed to the U.S. government? You might want to write this down. Patients, insurer, or the plan are retained by the PBM. Mr. Joyner?
Congressman Palmer, the program you're referencing was discontinued in 2023.
That program was discontinued?
Yes. Yes, sir.
Can you tell me what percentage of the funds were retained by in those categories up until then?
The program you're referring to was a performance-based network, and it was distributed to the high-performing pharmacies as a way of actually rewarding and recognizing and incentivizing high performance within the pharmacy network.
You're not answering the question. So what I'd like to do is, rather than go through this exercise of delay, is just have you respond, each of you respond in writing to the committee. Mr. Chairman, I'd like to make sure that they do that. The three largest PBMs control over 80% of the market and wield enormous influence over America's access to prescription drugs and the prices that the people who need those drugs have to pay. And the PBMs tout themselves as companies that are reducing the cost of medications for all Americans, yet the cost of prescription drugs and the spending on prescription medications have gone up every year for more than a decade. And so it just raises the question, how can you convince the American people that you're helping reduce the cost of prescription drugs when they've gone up so much? Dr. Kautzner?
Thank you for the question, Congressman. So for patients that we serve, in 2023, patients spent less out of pocket on average for 30-day prescriptions than they did in 2022, despite brand manufacturers raising prices on 60% of those drugs.
Well, what we saw is that some name brand drugs were costing 35 times more. Now, that's the information that I've been given at PBM-owned mail-order pharmacies than independent pharmacies. And so I don't understand why there'd be that much of a disparity. How could it be that on some of these drugs, and I'm not saying all of them, but on the PBM-managed mail-order pharmacies, they'd be 35 times higher? How do you explain that?
So, Congressman, I'd be happy to look at those individual examples and be able to get back to you on those pieces. What I can say is, on average, today, our employers make the decision on whether they want to have a home delivery pharmacy included in their network or not. So that's completely up to them.
But do you think it's acceptable to charge a substantially higher price through a program that, say, an employee has to be in than what a competitor would charge if they had access to the competitor's plan?
So our employers hold us accountable to ensure that we are administering benefits at their direction that are providing lowest net cost for patients and for them.
But
we help them
you
build
really
those benefit designs to do that.
It appears, I mean, there's a New York Times article that exposed how PBMs operate in in the marketplace, highlighting how they are driving independent pharmacies out of business, and they're not paying enough to cover costs. CVS Caremark overcharged an Oklahoma health plan for state employees $120,000 for just one cancer patient's medication. They also overcharged an Illinois cancer patient hundreds of dollars more than needed due to Caremark's formulary requiring her to use the more expensive version of the drug. Express Scripts forced a New Jersey retiree to pay $211 for his allergy medication when he could have gotten it for $22 at Costco. So each of you, I just want you to explain why you overcharge patients, employers, and the government at some fairly exorbitant rates, but often reimburse pharmacies less than it costs them to buy the drug in the first place. That doesn't make sense. You can respond to that. I know my time has expired. Each one of you can respond to that.
So our experience proves that we actually pay CVS pharmacies less than we do the other pharmacies in our network. And in fact, we actually have, when we do have people go into our pharmacies, they're paying on
Mr.
average
Joyner, you could pay a
4.7%
huge
less.
pharmacy like CVS less and still be overcharging this, creating a massive disadvantage for the other pharmacies because their volume's so much lower. I'll yield back, but let them respond, Mr. Chairman.
Gentlemen, time's expired, but please feel free to answer the question. Anybody?
Yeah, happy to answer the question, Congressman. So I grew up in rural America. I went to independent pharmacies growing up. I know that they are the major point for access to care for many underserved areas, both in urban and rural areas. Our focus as an organization has been to, one, help them evolve their business model to provide high-quality care in new and different ways, whether those are strep tests, biometric tests, behavioral screenings, those types of things. We also have convened an independent RX initiative for independent pharmacists. So we are convening on multiple times a year now 36 independent pharmacist owners to help work with them so that we can become more productive together, because we do agree that having independent pharmacies strong in our network is something that we feel passionate about. And actually, in the last year, we've had 1,400 independent pharmacies have increased in our network in the last year. So our work is paying off, and we are seeing more independent pharmacies continue to come into business and join our network.
Mr. Chairman, I just want to make sure that people understand that when you have these huge pharmacy chains that do a massive volume, that they could actually make less on per transaction, but because of the volume, still make a healthy profit than a smaller independent that doesn't have that volume. I yield back.
Gentleman yields back. Ms. Talib, or Mr. Kristamorte, Chair recognizes Mr. Are you ready, or do you want to leave? We'll go to Dr. Fox. Or I can go to Dr. Fox. You want to go? Okay. Chair recognizes an expert on PBMs, Mr. Kristamorte from Illinois.
Thank you, Mr. Comer. And thank you to the gentleman and the witnesses. I understand that you're here today to advance what I understand to be your shared position, namely, as the CEO of your trade association, PCMA recently stated, nothing can change the fact that PBMs have a proven track record of reducing prescription drug costs. Mr. Joyner, this is your collective position, correct?
That's correct.
Well, I'd like to just review some documents. First of all, in an interim staff report released this month, the FTC calls PBMs, quote, the powerful middlemen inflating drug costs and squeezing Main Street pharmacies. Mr. Joyner, that's what the FTC says, correct? It's right here.
That's correct.
Now, let me just point to another headline, this time in the New York Times. The headline of this New York Times article is, "The opaque industry," referring to PBMs, "secretly inflating prices for prescription drugs." Dr. Conway, you don't deny that the New York Times headline says this, correct?
That is the headline.
And further, at least 8 different states have filed lawsuits alleging that PBMs are inflating drug prices and engaging in anti-competitive behavior. In fact, Ohio Attorney General Dave Yost states, quote, Express Scripts has used its dominance solely for its financial gain, creating a complex pay-to-play rebate system that perversely pushes manufacturers to increase drug prices in order to be placed on or receive preferred placement on PBM formularies. Now, Mr. Katzner, you don't deny this is what Attorney General Yost said about your company, correct?
I don't recall seeing that exact quote,
Oh, I'll
sir.
just show you. It's right here. This is on their website. Ohio Attorney General Dave Yost. It says exactly what I said. You don't deny that's what Dave Yost said, right?
It appears that's what the document you're showing says.
So on the one hand, we have PBMs claiming to reduce prescription drug prices. And on the other hand, we have the Federal Trade Commission. We have major media outlets like the New York Times. We have at least 8 different attorneys general, Democratic and Republican, who all say that PBMs are inflating drug costs. I wonder whom the American people should believe. I want to turn to another topic. That's the question of DIR fees. And I see some pharmacists in the audience. They probably understand what I'm talking about here. DIR fees are the most insidious part of a class of fees known as post-sale adjustments or pharmacy price concessions. Essentially, DIR fees are clawbacks. They're clawbacks that PBMs get from pharmacies when the PBMs decide not to pay the originally agreed to reimbursements for the medicines that pharmacies have already dispensed in the past, in history. So let me look at the July FTC report and what they say about this. They note various public comments stating that DIR fees are unexplainable, create needless uncertainty for pharmacies, and are, quote, a charade. The Centers for Medicare and Medicaid Services says that pharmacy price concessions, of which DIR fees are a part, exploded by 107,400% between 2010 and 2020, a rate of increase that literally staggers the imagination. I'm not making this up. This number actually comes from CMS. This is not a typo. Mr. Joyner, this is what CMS says about pharmacy price concessions, correct?
Yes.
The top 5 executives at each of the corporations that own the PBMs represented today have all had significant increases in their paid compensation over the past 3 years. Andrew Whitty, the CEO of United Healthcare, earned between $18 million and $23.5 million. David Cordani saw his CEO compensation go from $20 to $21 million. Karen Lynch, the CEO of CVS, went from $20 to $22 million, all in the span of 3 years. All at the same time, we have these staggering DIR fees that have gone up by 107,000% over the last decade. At the same time, there have been 7,000 pharmacy closures during that time. So what's wrong with this picture? You have fees skyrocketing. You have pharmacy closures skyrocketing. You have drug costs increasing. And then you have CEO compensation at these different companies that are called PBMs also increasing. That is why Congress is scrutinizing this particular problem today. Thank you, and I yield back.
Gentleman yields back. Chair now recognizes Dr. Fox from North Carolina.
Thank you very much, Mr. Chairman. And I want to associate myself with the comments of my colleague from Illinois. There is great concern, and the numbers that he put out have to be paid attention to. As you know, I chair the Committee on Education and the Workforce, on which many members of this committee serve, and we've spent this Congress focused intently on improving transparency in health care and addressing the practices of pharmacy benefit managers, PBMs, in order to deliver lower health care costs to patients and plans. And again, as you've heard from members, this is a concern all over Congress. I'm proud of the House's broad bipartisan support for the Lower Cost, More Transparency Act, legislation that will require PBMs to provide employers the information needed to make informed healthcare purchasing decisions on behalf of their employees. And I look forward to continuing to work with my Senate colleagues to enact it this year. Today, we have CVS Caremark, Express Scripts, and Optum Rx, or the, quote, big three, end quote, represented, which own 80% of the U.S. PBM markets. And we need to know what impact this consolidation has on overall prescription drug prices. So, and I'm going to ask you to give succinct answers. With an increase in consolidation, what incentives exist for PBMs to negotiate better rebates? Mr. Joyner. Quick answer.
Yeah, thank you, Congresswoman. The goal here and how I'm measured by my customers is how my ability to lower cost for themselves and for the members they serve. So that's how I compete, and that's ultimately my, how they judge and value our performance.
Dr. Kautzner.
Congresswoman, we operate in a highly competitive environment today. Every request for proposal that clients put out, you will see a half dozen or more PBMs that are competing aggressively for that business, and we have to continue to extract value out of pharmaceutical manufacturers to show that value to patients.
Only a half dozen or more. That's a revealing number. Dr. Conway.
Thank you. We compete in a highly competitive market. We compete on clinical programs, transparency, choice, and lowest net cost, and the Optum Rx retention of customers is 98+%.
The Federal Trade Commission's interim report on PBMs found that your three PBMs increasingly rely on group purchasing organizations, GPOs, which receive roughly $7.6 billion in fees from drug manufacturers in 2022. Section 402 of the Lower Cost, More Transparency Act would require PBMs to disclose to plan sponsors fees received from manufacturers through GPOs. For each of you, does your PBM pass on fees received from drug manufacturers and through GPOs back to plan sponsors in the form of rebates or otherwise? If so, what percentage of such fees do you pass on? Mr. Joyner.
Congresswoman, we pass over 99% of rebates and administrative fees across our book of business, and in Medicare, we pass 100% back to the
Dr. Kautzner.
We do absolutely pass back rebates and fees to our clients. Many of our clients can receive 100% of those fees if that's the type of benefit design that they choose, and we charge a simple per claim fee for that type of service.
Dr. Conway.
Similarly, the majority of our clients have 100% pass-through of rebates. There are clients, and on average, we're 98+ rebate pass-through to clients as well, and it's their choice.
This committee has received testimony and documents that illustrate that transparent PBMs can achieve dramatically higher cost savings than your three companies. If that is truly the case, shouldn't all PBMs be transparent? I just need a yes or no answer. Mr. Joyner.
Congresswoman, we are transparent, so
Okay.
we compete in a transparent world.
Okay. Dr. Kautzner.
We are transparent as well and have transparent offerings that compete with other transparent PBMs.
Dr. Conway.
Yes, we are transparent to customers and to the patients we serve.
Mr. Chairman, I'd like to ask one more question, if you'll
Please.
indulge me. Thank you.
I've never told you no.
Thank you.
I'm afraid to tell you no.
I wouldn't tell you no either. In the employer-sponsored market, plan sponsors have a fiduciary responsibility to their employees to provide the highest quality plan for the lowest cost. How do large PBMs help employers fulfill their fiduciary duties? And again, a quick answer so I don't abuse my privilege from the chairman.
Today, we are contracted with our customers to deliver on the contractual commitments they've given to us. So, in large part, is making sure that we both deliver and execute against the guarantees and the contracts that they've negotiated with us.
Thank you. Dr. Kautzner.
Congresswoman, we focus on lowest net cost for our clients and for patients to deliver that value.
Dr. Conway?
Yes, we provide transparency and choice to our customers, including plan employers, and compete on lowest net cost and best clinical programs.
Thank you, Mr. Chairman. I appreciate the indulgence.
Chair now recognizes Mr. Conley from Virginia.
Thank you, Mr. Chairman. PBMs and Big Pharma play a blame game, don't they, Mr. Joyner? Big Pharma certainly sets drug prices in America and maximizes profit to its best ability. Would you agree with that?
I would.
Would you speak up in the mic, please?
So, yes, sir, I agree.
Okay. And this committee has had hearings on drug pricing in the past, including, in some cases, really egregious examples of price gouging on generic drugs, on very old drugs like insulin, for example, which haven't particularly been improved much over 100 years. How we deliver them, yes, but the basic insulin drug hasn't changed much. And as you know, that led to moves here in Congress to actually cap the price of insulin at $35 rather than have tens of millions of Americans suddenly not be able to afford a life-saving drug. Any views on that particular example?
I think CVS Caremark has a particularly strong track record in this one category. These are branded medications, and if you look at our ability to lower the cost of insulin, both for our customers, which has actually seen a reduction in cost for the plan sponsors that we serve, and ultimately the patients that are on these insulin therapies are paying less than $25 today. So we've done a really nice job, I believe, of using competition to lower costs for the customers that we serve, and ultimately to the benefit of the patients that are on these important therapies.
That's kind of a more recent development, isn't it?
No, sir. We've actually we created the competition back in 2012, and from that point forward, you've seen the cost of insulin continue to decline. And so the recent change where the manufacturer actually lowered their list price, so which we applaud, came after we actually negotiated significant discounts to lower the cost for our customers.
Do you believe that the move to, for example, lower the price of insulin might have had anything to do with growing political pressure, including political pressure up here, to force the hand of both Big Pharma and you otherwise? That is to say, lower the price or we'll do it for you legislatively. Do you think that had any relationship at all to the decision?
It's plausible. Plus, there was a
Plausible.
Yeah, and there was a change in the way in which the Medicaid priced this category. So, because they removed the cap, that actually would have penalized the drug manufacturer for the price increases that they've taken over the last decade.
So Big Pharma maximizes profits, but of course, so do PBMs, right?
Our job is to continue to lower the cost for the customers of which we serve.
Lower the cost.
Correct.
So when we compare drug prices in the United States to Europe or Canada, in your efforts to lower costs, do we see American drugs actually lower in price for consumers than in Europe or Canada?
For the generic drugs, which is 9 out of every 10 prescriptions in this country are generic medications, and we believe we've done a remarkable job of lowering the cost of generics in this
That's
country.
not my question.
The brands that actually represent the remaining 10 are more expensive than they are around the world.
Why?
Because the rest of the world negotiates for price in order to have access in their country.
Oh, so we don't do that.
Beginning in January of 26, our government will start the first 10 drugs that will be negotiated on behalf of Medicare.
And do you expect prices to come down with that negotiation?
I believe the PBM industry, and specifically CVS Caremark, has done a really nice job of lowering the cost of those 10 medications that are there, and our hope is that there will be continued reduction in cost.
Yes, we all hope for that. But I was asking about the actual process and what what the relationship is between that process and the expectation that there will in fact be lower drug prices. You just said our drug prices, in fact, are higher than most of the rest of the world. Same drug. And so we all want to understand on behalf of our constituents and consumers, well, why would that be? Why would that be if it's the same drug? And I think you've answered by saying, well, they negotiate prices, we don't. We're going to start doing it. We've got a list of the first 10, and that would suggest that consumers have been paying a premium simply for want of negotiation on prices for many years. Would that be a fair conclusion to draw?
I can only speak to the role of the PBM and the fact that we've done what I believe is a good job of creating competition and lowering costs. And I'll just look at the last 5 years. We've been able to reduce the branded medications by 15% by using competition in a free market to be able to lower the cost for our plan sponsors.
Yes, and good for you. But when you talk about lowering costs, it's relative to the previous price in America. It's not relative to the cost of drugs in other advanced, civilized places like Europe and Canada, right?
Correct.
All right. So when we say lowering the cost, there's lowering the cost and then there's lowering the cost. Hopefully PBMs will help cooperate in that regard. But I think it's really important, all of us believe that when a manufacturer invests R&D in a development of a new drug, that manufacturer takes risk and is entitled, within reason, to recoup costs. But when you take a 100-plus-year-old drug like insulin and you suddenly jack up the price just because you can, I'm not saying you did, we had hearings on that, that actually puts lives in jeopardy. And so maximizing profits, nothing wrong with that, but not at the expense of people's lives, not at the expense of people's health. And I think PBMs as well as Big Pharma have an absolute obligation, and so do we up here, in protecting consumers, especially when the system doesn't work for them. Thank you. I yield back, Mr. Chairman, and thank you for your indulgence.
Chair recognizes Mr. Timmons from South Carolina.
I appreciate my colleague across the aisle's remarks, but I think, with all due respect, you're missing the mark entirely. You're missing the mark entirely. Our country.
Well, not entirely.
Our country is sick. Our country is sick. Why is Europe and Canada paying less? Because they don't have an enormous obesity problem. Because half of them don't have diabetes. I mean, all of these are preventable diseases. They're all preventable diseases. Mr. Joyner, what percent of the drugs that you sell treat trauma injuries of some kind, or genetic abnormalities? What percent? 10, 15% of the drugs you sell?
I'm not sure.
I bet it's less than 20. We can all agree. So everything else is purely preventable. I mean, so we have all of these problems with drug prices, but we have a demand issue. We have a demand issue. This country is sick. I have been to, I have seen more people getting dialysis in the last 6 years. I go to these dialysis clinics at least once a year, and it's sad. And there's more of them, and there's more of them. And 95% of people that have diabetes that need insulin can exercise and eat better and not have these problems. So we're here to talk about who is making more money along the supply chain. Why don't we cut the supply chain off? Cut the need off. People need to be healthier. They need to take responsibility for their health. They need to exercise. They need to eat right. Our entire healthcare system delays death and treats sickness. We do nothing to facilitate health and wellness. And we talk about Europe. I mean, their diabetes rate is drastically less. So yeah, insulin's less. There's less demand. And the cost of insulin goes up because millions and millions of Americans are increasing the demand on it. 129 million people in this country have at least one major chronic disease. At least one major chronic disease. Heart disease, cancer, diabetes, obesity, hypertension are the lead. All of those are very preventable unless you have a genetic abnormality. I'll even use myself as an example. I owned a CrossFit gym. I worked out every day, and I went to the doctor. I got some blood work done, and the blood work came back. She said, "William, you have a cholesterol problem." I said, "I'm 10% body fat. I work out every day. What's up?" And she said, "Well, what do you eat?" At the time, I was eating probably 16 ounces of steak a day. She was like, "Well, there's your problem." So I reluctantly changed my diet. I ate some fish, had some shrimp, ate some chicken, go back, get my blood work done, not a problem. Could I, without any penalty, have continued eating 16 ounces of steak every day and gotten a pill, lived on that pill for the rest of my life, and received no additional cost to me as a person? Yeah, I could. That's our healthcare system. There's no accountability. And you know what's crazy? That cholesterol pill that I take after a couple years, I'm probably going to get a blood pressure issue. So there's a pill for that. And, let's just say I stop exercising, gain weight. There's a shot for that. I mean, this is not how our country needs to be operating. It's just outrageous. So we're here talking about drug prices. The way to address our healthcare system is by accountability, personal responsibility. We have to incentivize health and wellness and not delay death and treat sickness. So I realize I'm on my soapbox here, but we have a major problem in this country. We have some of the worst outcomes of any developed country, and we spend 4 times more. Average spending, almost $5 trillion? And we have one of the least healthy developed population in the world. So I get it. We're fighting over drug prices, who along the supply chain is getting what and how they're doing that. We have to go to the root cause. We have to reduce the demand for all of these drugs. Even the military is having a huge problem. We're having to constantly reduce our standards because we cannot field a professional military. This is a national security threat. We have $35 trillion in debt. We're adding $1 trillion to our debt every 100 days. And we have workforce issues because people are unable to work because they're at the dialysis clinic or they're too sick. And again, 90% of all of this is preventable with diet and exercise. So I understand that we're fighting over drug prices and who along the supply chain, but we got to go to the root cause, and we have to get serious about incentivizing health and wellness and stop fighting over who gets what dollar as we delay death and treat sickness. And with that,
Would the gentleman yield for a question?
Absolutely.
But I'm very drawn by your analysis, but would you take it one step further and say that Congress and the federal government should not be investing in big sugar, in big dairy, and in unhealthy agriculture practices that end up producing diabetes and unhealthy outcomes?
I do everything in my power to eat things that are from nature, and I'll leave it at that.
All right. Chair now recognizes Mr. Khanna from California.
Thank you, Mr. Chair. Dr. Conway, you're here as CEO of OptumRx, but before that, you were a doctor, actually a well-respected doctor, a pediatrician, as I understand it. And so I want to ask you, when you were a doctor, if you had a 10-year-old, for example, who came in with arthritis, and you recommended or prescribed Humira, do you believe that your judgment would be more valuable than some of your colleagues at Optum who may not have treated that patient?
Sir, I'm still a practicing pediatrician.
Wonderful. So can you answer the question?
In terms of clinical care, I believe clinical care should be based on evidence and the best medicine for the populations of patients.
But you wouldn't privilege the doctor's opinion in that case? If you were treating a patient, 10-year-old with juvenile arthritis, you say, okay, I think she needs Humira. Would you agree that your opinion should be given more weight than someone at Optum who may not actually treat that patient?
So I agree that prescriptions prescribed by physicians when consistent with the clinical evidence should be approved and given to the patient.
But that didn't happen in the case of Cassidy, right? Are you familiar with this case where she was a 10-year-old girl? She had juvenile arthritis, and her doctor prescribed Humira, but for 6 months there was denial of that medicine, and then the juvenile arthritis spread to her rib cage. Do you agree that that denial was wrong?
So for any individual case, we are happy to look into it with you and get back to you. I would go.
Do you know why that was denied?
I would go back to our process, which was an independent pharmacy and therapeutics.
Are you familiar with the process where you called utilization management?
We have an independent pharmacy and therapeutics committee, which has pharmacists and clinicians.
And what happened in Cassidy's case, because of utilization management, is the committee went back to Cassidy's doctor and said, no, don't give her Humira, even though the disease is spreading to her rib cage and she's in pain for 6 months, because you need to try cheaper drugs first. Is that what utilization requires?
So the vast majority of medications are approved when prescribed.
That's not my question, but is there a policy that you require people to try out cheaper alternatives first and that the doctor is overruled, as happened in Cassidy's case?
The vast majority of medicines are approved as prescribed. There are times when the independent P&T has recommended criteria that be followed, where at times one medicine is tried before another medicine.
And is cost part of the criteria?
The criteria start with the clinical standards and the evidence.
Is cost one of the factors?
No, the first criteria is the clinical evidence and criteria. If medicines are clinically equivalent, then the lower net cost can be considered.
So cost is a factor, and there are times, as in Cassidy's case, that the doctor's clinical diagnosis is overruled because of cost. I mean, the doctor was begging for this to be approved for this girl for 6 months as arthritis spread from her knees and her ankles to her rib cage. And it was denied again and again because they were saying that the doctor needed to prescribe something cheaper. Do you believe that that was an outrageous decision to privilege costs over this girl's health?
So as a practicing pediatrician, I said, and I've taken care of many children with juvenile arthritis, it is critically important to follow the clinical evidence to prescribe appropriate.
But why wouldn't you just say it's critically important to follow the doctor's recommendation? Can you commit to that today, that Optum Rx in the future will not have cases like Cassidy, and if a doctor is prescribing a medicine like Humira, will agree to fill that prescription?
For any individual case, for you or other member of Congress, if you want us to look into that case, we will.
But can you make a commitment today that you'll privilege the doctor's recommendation over the bureaucracy's recommendation? This is the heart of why people are so upset at the PBMs. Can you just make that commitment? That you will not override a doctor's, maybe, how about this? Can you commit that if a doctor recommends it twice, you won't override it?
As a physician, I hope you understand this. We value our partnership with physicians.
I'm sure you value it. So then can you commit to taking their recommendation? Why wouldn't you commit to taking their recommendation? Or can you commit to not considering cost, taking cost out of your utilization?
We are committed to the independent P&T committee that we have that is transparent, that includes independent.
It's like lawyers are writing your
pharmacists.
Statements.
I'm trying to answer your question, sir.
No, you're not, with due respect, sir. You're not committing to not having cost, and you're not committing to having a doctor's recommendation, even if they have it twice. That if a doctor says, we need Humira, it's denied. Then the doctor says, we need Humira. You're not even committing to accepting that, and you're not committing today, and this is, I'll let you have the final word, and you're not committing to taking out cost as a consideration.
We're committed to effective clinical care for all the people that we serve.
My time has expired.
Chair now recognizes Mr. Grofman from Wisconsin.
Okay, this is for any one of you. We're at the risk of a record number of pharmacy closures in 2024, which will only serve to make our pharmacy deserts worse. In fact, 1/3 of the independent pharmacies are currently at risk of going out of business. This is largely due to the PBMs, which engage in patient steering, spread pricing, which charges employers more for medications than they reimburse pharmacies. With the role you play in prescription drug reimbursement, how can you sit here and say that PBMs are not a major cause of these closures? Or do you agree it's a major cause of these closures?
Thank you for the question, Congressman. My 20 years of experience in this industry leads me to a different conclusion, as with the data, which would show today, we actually in the last 5 years have grown the number of independent pharmacies in our network from 18,000 to over 21,000. 1,400 net new independent pharmacies are in our network in the last year.
Your network, is that nationwide or just your network?
Our total network is nationwide, has over 64,000 pharmacies in it, of which over 21,000 of them are independent pharmacies. We also increased reimbursement to over 700 pharmacies across this country to address exactly what you just mentioned around underserved areas in rural and urban areas, so patients have access to care where they need it.
There's substantial evidence that PBMs often prioritize higher rebate medications over cheaper alternatives, which directly drives up the cost of patients. How do you justify these practices that seem to place profits over affordability? And what specific actions will you take to stop exploiting patients with unnecessary high drug prices, do you feel? Could you comment on that?
So we fight it every day to keep drug prices down. There are challenges with very high cost branded products. There are new products that entered the market last year, unfortunately had a median cost of $300,000 annually. So our focus is to bring down those costs. Some considerations that we're working through and we applaud Congress for doing is, one, reducing the patent thickets that 80% of the top 100 branded drugs put in place so they have monopolies on those drugs for much longer. That is a focus. Two is to make the biosimilar interchangeability pathway much easier, so physicians don't have to get a new prescription for those drugs, and you can enter biosimilar competition much sooner. As my example earlier this morning on Humira, the primary patent expired in 2016. They kept biosimilar competition from entering the market until 2023. When it did, the price net cost came down 38%.
Amen, brother. Do you think the American system of researching drugs is to a degree broken? Not enough emphasis on biosimilars, not enough emphasis, I guess I'll say, on drugs that make the pharmaceuticals more money. Do you think that's true?
I think that as Representative Timmons mentioned, there's less of a focus now on some of the larger chronic disease states that so many Americans unfortunately have, and there's much more of a focus in drug manufacturers on very rare conditions. Some of those conditions they move to for ultra-rare, ultra-orphan type products because there is less competition, and they will have a monopoly on those drugs for much longer, which will increase their profits.
But in general, research overall, including university research, are they too focused on, I guess, because the government pays for a lot of that research, are they too focused on, or not focused enough on biosimilars, not focused enough on generics, not focused enough on things that may be cheaper, instead are spending the research dollars, including at the universities, on things that are going to result in higher costs?
From my view and my experience, there are times where there isn't enough competition in certain cases, and competition is where we drive savings in this competitive market. So whether it's biosimilars or generics and the lack of those competitive products in those areas, yes, that becomes an issue in certain conditions.
Do you feel that some of that is the university's fault, or is it the government who's telling them where you have to put your research dollars?
That question's probably outside of my scope of expertise. We'd have to get back to you on that piece.
Okay. I guess that takes up my time.
The gentleman yields back. Chair now recognizes Mr. Mfume from Maryland.
Thank you very much, Mr. Chairman. My thanks to both you and the ranking member for convening us for a third time to talk about PBMs and to allow us the opportunity, in this case, to have the three major players before us. I'd like to, before I begin, recognize a group of retail pharmacists from my state of Maryland who are here and who have been very helpful with me and others in terms of helping us to understand their plight. They are seated in the audience here. And I would ask, Mr. Chairman, unanimous consent to enter into the record their letter in support of continued bipartisan scrutiny of pharmacy benefit managers.
Without objection, so ordered.
Mr. Chairman, I would also ask unanimous consent to enter into the record the American Federation of State, County, and Municipal Employees letter advocating for increased transparency for PBMs.
Without objection, so ordered.
Thank you, sir, and I will pass those down and we'll get those right to you. According to the Kaiser Family Foundation, last year in 2023, 30% of Americans reported that they were unable to take their prescribed medication as needed due to exceedingly high costs. That's not me. That's 30% of the people in this country who were asked. In fact, my office has met with the Asthma and Allergy Network recently, who conveyed that many parents in my district in Baltimore, as I'm sure is the case in other districts around the nation, are forced to forego their own medical needs to ensure that they themselves as parents are able to afford the ability to purchase medications like inhalers and EpiPens for their children who are in pain and who suffer and who need that sort of treatment and those sort of medications and other things. In addition, some of those families have multiple children. And in those instances, those children who have the same ailments must share the same inhalers, EpiPens, or other things that are prescribed. Gentlemen, I don't know about my colleagues here, but I find this absolutely unacceptable. And I think, Mr. Chairman, that we've got to find some sort of bipartisan path to bring about regulation. Otherwise, we'll be faced with the possibility of having a fourth hearing. Hubert Humphrey said something that bears repeating. He said that the moral test of government is how that government treats those who are in the dawn of life, how they treat those who are in the twilight of life, and how that government treats those like the elderly and others who are in the shadows of life. We're not doing a good job when it comes to prescribed medications, because what we're doing is to push them further into those shadows. Now, I know that I could be a band of one on this, but I'm never going to stop banging this drum because people are hurting. And I just don't understand, to the three of you who are here, how is it that you're right and the Federal Trade Commission is wrong? Help me to understand how you're right and the attorney generals of 8 states, and it could be 9 as of today, are wrong. Please tell me how the analysis done by major media outlets like the New York Times and others underscore this problem, but they are wrong. And please tell me how pharmacists and doctors say that you are the problem and you say they are not. So I think this begs for an approach that's bipartisan and one that finds a way to correct this issue. Quite frankly, I'm tired of running around and playing Ring Around the Rosie. Now, I'm not saying you should not have any sort of profit margin, but I think those margins are exorbitant. I have yet to see the formulas, even though you say you're transparent. I don't know what formulas you use to come up with the pricing. You know, is it sleight of hand? Is it now you see me, now you don't? This is crazy. This is absolutely crazy. And I would go so far to say it's anti-American. And for my colleague who said earlier that 90% of all of this can be corrected, that is preventable, there are cases of obesity that are generic. There are cases of cancer that go back to generic disposition. I could name a ton of other diseases that you can't prevent that are not a part of this so-called 90. And these people need help. They need to be able to purchase the medications they need without a lot of sleight of hand. So I have yet to see the transparency, with all due respect. My time is concluding, but Mr. Chairman, I would welcome any opportunity that you and the ranking member put together that we might be able to find a way to address this problem once and for all for Americans all over the United States. I yield back.
The gentleman yields back, and I agree. Mr. Mfume, look forward to working with you. I will remind, we passed a PBM piece of legislation that impacted the federal employee health plan that came through this committee. That was our sole jurisdiction on it, but we're going to continue to work together, and I pledge to work with you in that endeavor in a bipartisan way. Chair now recognizes Mr. Burleson from Missouri.
Good afternoon. I guess I'm part of a dying breed. I'm still a free market, believe in capitalism Republican, which is apparently rare in this town. I happen to agree wholeheartedly with my associate, Mr. Timmons, that we have dramatically removed all costs in any kind of decision making from patients, all through the regulatory schemes that originated here in Congress. And so we further continue to try to remove any kind of negotiating power. And then we wonder why healthcare costs just continue to skyrocket year after year. And yet we have this one example where healthcare costs are not. And so, but yet it seems, just from hearing this, what I've heard today, you guys are forcing yourselves on your customers. That you're almost do you literally put a gun to the head of the businesses that hire you, that pay you, Mr. Joyner?
Not at all. In fact, they hire us to do a very specific job, and as we've said earlier, very high satisfaction rates.
And if they're not happy, they have to continue to pay you, right?
Exactly. They have choices and options.
So if they're not happy, if the price is too high, just like in the normal market, they can choose someone else. There's apparently 70 different options, and yet we're here wanting to dig deep into your pricing structure, get involved in your profits. That's what's remarkable to me. Now, look, I do have concerns about my independent retail pharmacies, and I was pleased to hear that you guys are engaging with them. I'm going to get to that question next, but if the product that you're offering is so bad, let me ask this, and I think this would be telling. Big pharma, pharmaceutical companies, they obviously don't like you, right? You guys negotiate down pricing, but do they utilize you, Mr. Kotzner? Pharmaceutical companies have employees. Do they purchase, and this will be very telling, do they use pharmacy benefit managers to manage the insurance costs of their own employees?
Congressman, yes, we do have clients who are pharmaceutical manufacturers.
Why in the world would they choose? Obviously, you're forcing yourself on them. You're forcing yourself for them to purchase your services, right? The services that they say are so egregious, and yet they choose to hire one of you to manage their own employees' costs. I think that that's evidence enough, but I want to get to what can we actually do to reduce the costs of pharmaceuticals for patients, and I'm trying to be creative. Think of what can we do to deregulate instead of what this place does is just add more regulations, try to get into the lives and the businesses that as much as possible. What regulations could we look at that would actually empower independent pharmacists and hopefully provide better access to patients? And I would like to hear from each of you.
So, Congressman, I think our track record speaks for itself, which you mentioned earlier. The PBM industry, specifically CVS Caremark, has been very successful in creating competition to lower costs for our customers. And if you look at the generic medication adoption rate, it's 9 out of every 10 prescriptions is a low-cost generic. The remaining 10 that are brands, we use competition to effectively lower the overall cost. So between 2017 and 2022, we were successful in lowering the brand medications by 15%. So I do think that the PBM model does work in terms of creating competition and lowering cost. I will add on that I think what the concern here is the out-of-pocket cost for the members, and in large part that's what we've delivered, introduced a new pricing model called True Cost, because the idea now is to make sure that the member gets exposed to the lowest net cost. That's in fact what the pricing model is inherently designed to do, is make sure that it gets closer to the acquisition cost, making it simple and easy for the patient to access the medication.
So, Congressman, in regard to independent pharmacies, you're from Missouri. I live in Missouri. There are unfortunately 20% of Americans living in rural America today, and only 10% of Americans' physicians live there. That creates an access to care challenge. Independent pharmacies can help fill that challenge by allowing them to work at the top of their license, expanding scope of practice opportunities.
100% agree.
They have those opportunities and they can get to the patients that need them most. When I was a kid, I used to go to an independent pharmacy because it was hard to get into a doctor at the time. It's that type of work that we need to work together on and partner to be able to do, and that will have a real effect in communities.
So,
Oh, I'm sorry, go ahead, answer the question.
yep, I'll be very brief given the time. We agree with your points that transparency, choice, and a competitive market serve our customers. They value that choice, as we described, and we continue to drive both affordability initiatives to consumers and support for independent pharmacies.
I really appreciate your comments, and I wholeheartedly agree. I'm going to be pursuing an effort to try to reevaluate what pharmacists are allowed to do to try to increase their scope, because at the end of the day, we need more healthcare providers, we need better access to healthcare, and we need to improve their ability to get reimbursed. And I think this may be a win-win. Thank you.
Gentleman yields back. Chair now recognizes